Hello everybody, my name is Rami Apelian. I'm a neurologist and epileptologist here in Southern California. My particular interest is in epilepsy in the elderly, and that's what we're actually here to talk about today. I know some of the earlier talks today have really been kind of focused more on the clinical and the treatment options or the to-dos or what not to do's, and that's really not what my goal here is today. I really kind of want to introduce this concept to the community and really increase awareness about epilepsy, particularly in patients as they're aging, because patients above the age of 65 tend to be at higher risk for seizures and epilepsy than patients who are pediatric. And I'm going to show you some of the statistics that support that. So that's really the purpose of today's discussion, is to educate and to really kind of bring this issue into the forefront. And I kind of want to do this, this thing's really quick, with a cartoon. These opportunities to actually talk to patients are really important. When I'm in my office and patients in my office talking to me about their experience and I'm trying to communicate some of the clinical information, a lot of that can often be misconstrued. And what I think I'm telling the patient and what the patient actually receives and takes home is often very, very different. And this cartoon is actually very effective at illustrating that. This young man here in the cowboy hat had a seizure. They told him he had a grand mal, and at the end of it all, he actually completely misunderstood what the exchange was about. It wasn't about his seizure in his mind. It was that he thought he had inherited a shopping center. So why is this important? And really, this is the key epidemiological information that we have to cover. Epilepsy is the most common serious neurological disorder besides stroke and dementia. And what's even more concerning, and as we'll go through this, stroke and dementia are actually two of the biggest risk factors for development of epilepsy in the adult elderly population. 25% of internists and general practitioners, family practice docs who were polled could not identify that epilepsy can develop in adulthood in the absence of any childhood epilepsy. Okay? Let's think about this. 1 in 4 doctors. 1 in 4 doctors are missing the ability to make this diagnosis. Epilepsy, childhood incidence, about 40 to 50 per 100,000 patients a year. But as you get older, between the age of 40 and 59, that number is already higher. The incidence of having your first seizure is 50 to 60 per 100,000, and after you cross age 65, that number nearly triples to 136 per 100,000. And these are in identified cases. So if we think about the fact that epilepsy may not even be identified in these patients, the actual numbers are probably higher. The other thing is that older patients are more frail. Older patients cannot suffer a fall and sustain less injury the way a younger patient can. Osteoporosis is a big issue. So if a patient is to fall, they could actually break a hip a lot easier. Head injuries are more common in epilepsies in older patients than they are in younger patients. And of course, status epilepticus is obviously a very big concern. And if you're older, you are higher mortality. You are more likely to die if you go into status than a younger patient. So there are really 4 purposes, 4 goals here in today's discussion. The first is to really identify the age profile of the development of epilepsy. We're going to talk a little bit about the risks of seizures at any age. Why are we trying to prevent seizures? Why are seizures difficult to identify in older patients, and some of the challenges in treatment. We're going to knock this out in about 20 minutes. So let's start with the age profile. Dr. Rowan published this in Neurology in 1998. So this is even before we really started to identify epilepsy as more of an adult disease. And I would guess that if we actually looked at this graph with modern data, we would probably actually see a steeper increase over the age of 60. But here in our dark black line, we have generalized onset seizures. In the white dotted line, you have partial onset seizures. And you can see early on in life, generalized seizures are more common. And as we move along life, there's a bit of a plateau regardless of seizure type. And then after the age of 60, there's this huge uptick in partial onset seizures between the age of 60 and 80. And now 80 isn't even that old. Quite frankly, 80 is the new 60 is what I tell my older patients. So If we actually kept going to the age of 90 or even 100, that will continue to rise. If you look at the difference between men and women, there really isn't any. This is not a gender-specific disease. This is an age-specific disease. So let's talk about the differences between risk factors for development of epilepsy in younger patients versus the risk factors in developing epilepsy as an older patient. Younger patients are often having seizures as a result of complications in their neurodevelopment during pregnancy. So prematurity, one of the big consequences of prematurity is possibly bleeding in the brain or abnormal blood vessels in the brain. Children after birth can develop cerebral palsy. Children who are under the age of 1 are at risk for febrile seizures or seizures when their temperatures are very elevated. Having autism is an independent risk factor for epilepsy. And if you have a family history of epilepsy, you're more likely to develop epilepsy as a child. So what we're seeing in the red box, that early part of the age curve, are related to birth and family contributions to a child's risk of developing epilepsy. Now, as you're in your 20s, your 30s, the bigger risk factors are head trauma or illegal drug use. And this is why we start to see the curve slightly diverge over the age of 20. Because partial onset seizures, because of some of these injuries or exposure to drugs, is actually what causes that to go up. But then what happens? You get over the age of 60 and you're now at risk for 3 very serious conditions: stroke, neurodegenerative disease, and trauma. And neurodegenerative disease really is just a fancy term for Alzheimer's in this particular situation. But if we actually talk about stroke, stroke is almost 50 to 75% of the cause of identified secondary seizures and secondary epilepsies in older patients. So we want to reduce the incidence of epilepsy in older patients. The first thing you do is you try to reduce the risk of stroke, quite frankly. But then after the patient actually begins developing seizures from their stroke, what are we going to do? How are we going to treat them? Typically, epilepsy does develop about 3 to 12 months after a stroke. It can be as long as 2 or 5 years. Rarely is it below 3 years. And if you have a seizure at the time of your stroke, it doesn't actually even mean that you're going to develop epilepsy later on in life as a result of that stroke. Those are 2 independent variables. And if you have a bleeding type stroke, the hemorrhagic stroke, where the artery bursts, we call that the burst pipe, you're more likely to have epilepsy and seizures developed than if you had an ischemic stroke or one of the strokes where the artery got clogged. Alzheimer's disease is another independent variable that increases your risk of developing epilepsy by 10 times compared to an adult who does not have Alzheimer's. While the risk is substantially higher if you do have Alzheimer's, the number of patients who have Alzheimer's who actually go on to develop epilepsy is only about 10 to 20% of the adult epilepsy patient population, so it's not a large contribution like the stroke patients are, but it certainly is a significant one. And head trauma, particularly after a fall or with patients being on blood thinners for various cardiac reasons or blood clots. Head trauma is another very significant risk factor for developing a partial onset seizure and ultimately a focal epilepsy, accounting for about 20%. Now, I did put brain tumors up here, and the reason this is up here is not because seizures cause brain tumors, but on the other side of the spectrum, oftentimes brain tumors aren't identified clinically until a patient actually has a seizure. And what ends up happening is there's a slow-growing tumor in the brain or some sort of metastasis from a different part of the body, and the patient's going along just fine, the brain is operating just fine, and then one day the patient has their first seizure and they end up in the emergency room with a CAT scan or an MRI, and all of a sudden the brain tumor is identified. And that's an important thing to remember, is that a seizure is a symptom. A seizure is not a disease. Epilepsy is the disease, and that's really what we're talking about here with the brain tumor patients, is that the symptom of the tumor being present and causing irritability of the brain, that's the seizure. Okay, so we talked about the age profile. We talked about kind of how the adults and children are different. I'm going to kind of go quickly over the risks of having seizures. This is obviously not anything new to anybody in this room, but I think it's a nice refresher to keep us informed on what it is we're actually trying to prevent in our patients. Obviously, injuries, car accidents. In elderly patients, we're talking about patients who are driving or who may have been driving before they had their seizure. What if you had your first seizure when you were behind the wheel? No one thought you were going to develop epilepsy, so it's really important that we actually screen for this. Obviously, drowning is a very serious complication. Anytime somebody has a newly identified seizure or epilepsy, before medications are stabilized and we know that they work, we always ask our patients not to take a bath or go swimming by themselves. Always have someone present. In mothers who have epilepsy who just gave birth, we ask them not to give their children baths without supervision because we don't want a mother to have a seizure while she's giving her child a bath. Polypharmacy is a big issue, particularly in the elderly patients. Patients who are older are on drugs for their heart. They're on drugs for their blood pressure. They're on drugs for their cholesterol. They're on drugs for their diabetes. And now you're throwing in drugs for their epilepsy as well. So drug-drug interactions and how the drugs interact with one another and ultimately the different disease process becomes a very serious issue. The top 3 side effects for just about every seizure medication out there. I'm looking out in the room and I see reps from every different product, and if your product does not have dizziness, somnolence, and drowsiness as your top 3, we should talk. But then the most common side effects of every anticonvulsant. And as you add more drugs, the likelihood you're going to have these side effects increases. And we know that it's not just one drug plus one drug equals the combination of side effects from the 2 drugs. We also know that there is an additive quality that makes it a little bit more of an exponential side effect profile. And we also know, unfortunately, that epilepsy does come with a heightened anxiety and depression as comorbidity. And we have to think about this. Why is this? The most obvious cause is the unknown. And in the unknown, it's when am I going to get better? When can I start driving again? Or when am I going to have my next seizure? And again, thank you for Johnny Optimism for outlining this so well in this cartoon, albeit a little bit sarcastically, but at the same point, if we don't put ourselves in the shoes of our patients and realize that there is this heightened anxiety, this heightened depression as a result of being now disabled by the epilepsy, we're missing the point. I mean, that's really why we're trying to treat. We're not trying to treat the seizures, we're trying to treat the patient. And so really the psychological problems are a big factor. The other thing is that we also know that the patients with epilepsy have different brain architecture. They have a seizure focus, and that brain architecture problem in and of itself can also be associated with some depression and anxiety. Of course, we're always trying to prevent against the big, bad, nasty elephant in the epilepsy room, which is SUDEP, sudden unexplained death in epilepsy. That in and of itself actually deserves a slide. For those of you in the room who don't know what SUDEP is, it means that we as physicians haven't done a good job educating you. Basically, 1 in 1,000 people who have epilepsy are going to die from this condition. And it's sudden, and it's unexplained, and it's death. It is not attributable to any seizure. Most of the time, patients are found in bed first thing in the morning. They've passed away with no signs of a seizure even occurring. The bed sheets are not unmade. The patient is exactly in the same position they went to bed in hours earlier. And really the risk for developing SUDEP is uncontrolled seizures. So really the aim here as a physician is to reduce the risk of this occurring by trying to get as much seizure control as possible as early on as possible. It's actually thought because patients with epilepsy have abnormalities in the control of their automatic nervous system, the autonomic nervous system, that the heart stops as a result of this, but we really actually don't know what's happening with SUDEP. Okay, so identifying and treating seizures. This is actually the big thing. Why are seizures difficult to identify in older patients? The first and easiest reason for this, before I go on to any slide, is that unless you are a completely negligent parent, a child is always supervised. Every child has an adult with them, whether they're at home, at school, in daycare. But elderly patients are often living alone. They don't want to be living with their kids. They are having spells or events that are completely unwitnessed. So having a heightened awareness of the fact that this can actually occur actually is one of the biggest ways to reduce the risk of patients developing untreated epilepsy. And the rest of them, the rest of the risk factors are actually detailed very well in this video.
We were having dinner and we went into the living room and we sat to talk for a while, but I don't know how to explain it, but all of a sudden something didn't feel right, and I didn't know where I was, and I didn't know what we were talking about, and I felt like I was watching myself, like in a movie. And after that, I couldn't remember anything until I saw my daughter in front of me and talking to me.
What did you see?
Well, my dad got this faraway look in his eyes, and I could tell that he had stopped listening to me. So I asked him if he was okay. He didn't respond. He was just kind of looking around, and I noticed that his left hand was shaking a little bit, and then his left foot. It lasted maybe 2 minutes, and I kept saying, "Are you okay? Are you okay?" And after about maybe the 5th time, he responded that he was all right, and he had just had a dizzy spell.
And did you feel confused or groggy?
No, I felt a little confused for a few minutes, but then I felt tired, and so I went in to lie down.
Yeah, Dad didn't want to go to the hospital, so my husband took the kids home. I stayed the night with him, and nothing else happened. He managed to get some sleep. He really didn't want to come in today, but I told him I thought it was a good idea.
Well, Doctor, I feel good today. I mean, I just got to realize that I'm getting older, and maybe this was just a drop in my blood pressure or something like that. That's all.
It's always important that we find out what's going on when something like this happens. It could be a number of things. I'm going to ask some questions, and then maybe we'll do some tests. But first, has anything like this happened before?
Well, actually, about...
I love that part. The daughter always has to throw in something extra, but it's true. And these things do oftentimes come back when we start talking to patients, that they have had spells that are difficult to characterize, maybe associated with dizziness or something that they're just attributing to some other rational explanation. Oh, my blood sugar went down, or my blood pressure went down. That's another difference really between adults and children. Children just say something's wrong, and it's up to the parent to kind of figure out what is wrong. Adults are going to try to rationalize things themselves, and that's one of the barriers in elderly patients for identifying and treating seizures. Oftentimes, seizures can just be more subtle. Patients end up in the hospital because they had, quote, altered mental status. As a neurologist, this is one of the most annoying consults I can receive in the emergency room because anything can cause someone to be confused or altered. So really getting to epilepsy as a source becomes a huge barrier because a patient's probably been in and out of the hospital with a urinary tract infection or a low sodium or a low blood pressure before. But now I have to try to convince the patient that we need to look at epilepsy as a possible cause. Patients zone out. We all zone out. Mom and dad talking at the dinner table, dad stops listening, right? But when does it become pathologic? When is it something that we actually have to identify? And really trying to understand that not interacting is not normal in an older patient is sometimes one of the biggest barriers. Oftentimes seizures are just confused as episodes of confusion, or just dad becoming more forgetful. But when someone actually does have a convulsive seizure, the other thing is that older patients just don't recover as quickly. And this is a big issue because these post-ictal periods, the time after a seizure, the time to recovery to get back to normal, can last days or even weeks in an older patient. Even adding new medication after treatment of seizures, patients can have much longer side effects. So everything in an older patient just can take longer. And then, of course, there are the common things that people often confuse with either epilepsy or are dismissing epilepsy as, oh, he had a fainting spell. Oh, dad just has a tremor in his left hand that comes in every once in a while. I can't tell you how many times I've diagnosed patients with epilepsy who have come to my office for an evaluation of Parkinson's. They don't have Parkinson's. They're actually having focal non-dyscognitive seizures. Sleep disorders, abnormal movements in sleep, twitching, kicking. We know that a lot of epilepsy does manifest overnight, typically in the 3 a.m., 4 a.m. window. But there are also abnormal movements of sleep that can be confused for epileptic events or vice versa. So really teasing out what's going on. And of course, anytime you have a loss of function, stroke or a transient ischemic attack are in the differential. And as we all know here in this room, after a partial seizure, you can actually be temporarily paralyzed. It's called a Todd's paralysis. And of course, there's always the multiple medication issue again. Is this a side effect, or is what we're seeing a side effect of drug-drug interactions? Okay, so which medication is right for me? And with this, I'm going to introduce you to another cartoon, which is that every medication comes with a long list of side effects, or in this particular case, slide effects, because the children are being warned not to slide across the floor in their socks. But at the end of the day, sorry for everybody in the room, but there's no ideal anticonvulsant for an elderly patient. Why is that? I mentioned all seizure medications are associated with side effects: somnolence, dizziness, sedation, balance problems, which are all really big issues for older patients to begin with. And unfortunately, these are the things that I have to contend with as a prescriber. I took the Hippocratic Oath. I said I'm not going to do any harm. First, I'm going to do no harm. But unfortunately, we take for granted that the things that we are doing as treatment can also have negative effects. I mean, a number of seizure medications come with long-term health problems in and of themselves. Loss of bone density, affecting the bone marrow and ultimately your platelets, your cell counts, your anemia, your ability to fight infection. And some of the older seizure medications themselves can also cause other balance problems by virtue of creating a polyneuropathy. Additionally, age just changes how drugs work in the body. Your kidneys are not as efficient. Your liver is not as efficient. Your nutritional state is different. Quite frankly, older patients are actually less nutritionally sound than younger patients. And this is going to affect how drugs are absorbed in the body. This is going to affect how drugs are circulating, and ultimately how drugs interact with each other. The more medication you're on, the more likely you are to experience side effects or drug-drug interactions. So that's really some of the stuff that we have to contend with here, treating epilepsy in the elderly. And I thank you guys for your time. Feel free to come by and say hi. I'm happy to talk to you about your experiences or the experiences of any of your loved ones with epilepsy, and thank you.